Hello and welcome to the EMSNation podcast. We're your hosts, Faizan Arshad.
And I'm Chris Fullagar.
Happy Thursday of EMS week, folks. Next up on our ambitious set of podcasts is David Olvera, the effect of human factors on outcomes in advanced airway management.
So this one is actually quite interesting and very timely. One of the issues in regard to the human factors with advanced airway management, particularly when we do RSI or a procedure that requires very specific steps, is that we can take a lesson from other industries such as the airline industry, in which the steps they need to take are so important when lives are on the line. If they miss a step, it can be catastrophic. When dealing with airway management, the potential risks are no different. So in order to mitigate this, one of the things that is becoming extremely important is the use of checklists. We've actually implemented that in our pre-hospital environment, in that anybody who is going to receive sedation and paralysis for definitive airway management, prior to that we go through a checklist that outlines each and every step. Now this could be thought of as an extra step, and why do I really need to do this if I'm facile in performing this procedure? But it is very easy, especially at 3 in the morning, to miss a step. And the risks, including the time costs of a delay as a result of a misstep, can be disastrous. Not only are we doing that in the field, but we're adapting this to the emergency department, where in the emergency department that I work in, we have now implemented essentially an identical checklist to the rapid sequence intubation procedure that we do out in the field. So it is something that is gaining importance and worth serious consideration as you develop your training and protocols for this important process.
Well said, Chris. I could not agree more. I actually just watched the movie Sully, where Captain Sully famously landed his A320 on the Hudson River. And I actually wasn't aware of the incredible controversy regarding the NTSB investigation into the landing. And they were essentially making the argument that had he turned around and or rerouted for another airport like Teterboro, for example, he could have been able to land. And he very famously said, but you did not consider the human factors in that simulation. And so whenever it comes to any critical procedure, we have to first and foremost understand that we are human beings and are inherently fallible. And when we have the privilege of caring for that tenuous patient, that critically ill and injured patient that requires an advanced airway, it really behooves us to take that extra step and run through an RSI checklist to ensure that we are not missing anything, number one, and number two, prepared for any adverse consequences that may occur during that critical procedure so we can optimize the patient's care. And I really appreciate your point regarding the use of RSI checklists within the emergency department. I think certainly as EMS medical directors, we have been advocating and arguing for the implementation of pre-hospital RSI checklists. But you have to train like you fight, and you have to practice what you preach. And I had, not been using an RSI checklist myself, and recently started doing so within the emergency department when I intubate. And I found that it has definitely saved me for tough tubes. Having my backup and secondary devices ready and prepared and tested is definitely in the patient's best outcomes. And then more so in regards to the human factors, I find that I'm able to get a better control of my own pulse before checking my patient's pre-RSI vitals, and it brings a calm and presence to the room, and it really helps the nursing and the techs that are in the room with me while we do that critical procedure. So enjoy this one by Dave Olvera.
So we're going to talk about human factors. We're going to kind of break things down a little bit, and we're going to talk about airway management and the ever inevitable RSI card. If you guys haven't heard all week, that's been a topic and trend, is checklists and cards and checklists and cards. So we're going to bring that together with all this today. There's my information. I'm the clinical education manager. I work on the community-based services side of Air Methods. So some of you guys that work or have a helicopter through Air Methods might not know who I am because it's of the hospital-based or our ADM model. I have no disclosures to put out for this presentation. And the objectives we're going to discuss, the application of human factors and related to RSI. We're going to integrate that evidence-based practice and talk about a few research articles that are involved with this. And then we're going to identify necessary components of this pre-hospital RSI checklist. Air Methods developed their own over the past few months, and have been beta testing it and putting it together, and it's finally in its final rollout that will be going live here in the next few weeks. And we'll talk about kind of what we did to kind of develop our checklist. So human factors. So what is human factors? What does it mean to us? So it's a study of all factors that make it easier to do the work in the right way. It's a very general term. It applies to whenever humans do work. Can we make mistakes? We absolutely can. Are there things that can make those mistakes happen more prevalent? It's also known as ergonomics in some areas. Now, the interesting thing about this, in medicine, this is still kind of new. But for a long time, it's been recognized in aviation, in nuclear power, in the military. There's checks and balances that have to go through to make sure things don't happen. You've all seen the Hunt for Red October, right? What would have happened if they didn't have the checks and balances in place and they just turned that key, right? So we think about that. How about our pilots in aviation? What if they skip those checklists? What have we seen happen? When we can talk to those people afterwards, we find out about those checklists being skipped. What do they say? If I would have used my checklist, we could have made a difference. All right. Human factors continues with the assess human cognitive and physical abilities of their overall work system. So this can be applied to not just medicine, not to just our high-stress environments, but our daily environments and what we do. When you wake up in the morning, you usually have a pattern. When you get launched for a flight, you have a pattern, right? You know what you do. You say, okay, my boots are over here. I put them on. I better put my flight suit on first, right? Yeah, so we do that first. We have these patterns in what we do. We recognize that people will make mistakes. That ties into just culture also, right? We don't immediately fire somebody for making a mistake. We make sure that the checks and balances were in place to offer that person the opportunity to clearly have the best outcome possible. And if they don't, then what do we need to do as a system to help improve their success? The idea is built a system where error can be reduced and provide safer care for patients. So what do we do now with our Pyxis? You know, in the Pyxis that I work at and that I use, I have to verify a dose with certain medications. I can't just pull out the full dose anymore. I have to verify with somebody, have someone double check it. In our pediatric doses, we do that as well, right? What's that thing that we use that we lay next to the patient, our pediatric patients? That weight-based measuring device? So we've been doing this kind of for years. We just really haven't applied the two together. So why is it important in healthcare? Well, like I said, it's recently been acknowledged as something to do. You guys have heard it all week this week in all the presentations. Somehow or another, we've talked about human factors, decision-making, and what we're doing in all aspects of our career industry. It's a major contributor to adverse events. You know, there's an episode of ER, I know I'm dating myself, but the doctor walks in and he goes, I don't even intubate babies. And he goes, what size tube do I use? And he looks at the nurse, and the nurse says, I don't know. He goes, well, let's just do 2.5. You know, but he had no reference, he had no idea what he was doing, and guess what? He was clearly wrong. And when the peds intensivist came in, they laid out that weight-based measuring device. They saw what the appropriate dose of the medication was. They saw what everything was, and things kind of settled down a little bit. All healthcare workers need to have a basic understanding of human factors. I think that's true. I think it's from the lay provider, from the volunteer, all the way to us at the critical care level. We have to understand that things can happen. We become complacent, right? We get distracted really easily. I think a lot of us in the HEMS world really do get distracted. We see those spinning rotors. We're like, oh, cool. You know, and you forget about your patient for a second. So having those distractors. So there's some science behind it. And really, they say they want to figure out human factors. How was that mistake made? Why was that mistake made? Could we have prevented it? Or what can we do? What can we learn from that mistake to be better? And I think that's why you guys are all here. We want to better ourselves in clinical education. We want to better ourselves in process. And most of the time, it's not the fault of the individual per se, as we failed as a system to get that person to where they need to be. Right? We have all these things happen to prevent errors and having all this occur that we really have to be careful and watch what happens with our design. But now let's apply it to something outside of medicine a little bit. Us. I'm going to tell you guys a personal story. Sometimes our brain gets too smart for ourselves. What do I mean? This is my fiance and my son. They are my world. They are my absolute life. And they are the greatest people I know so far in life, and they do so much for me. My fiancée is a type 1 diabetic. She's been a type 1 diabetic for 20 years. You know, and we joke and we say laughter's the best medicine unless you're diabetic and you need insulin. Let me ask you, with 20 years of the type 1 diabetic, with her regulating her sugars herself, does that make her an expert? Think about it. So let's talk about what the definition of an expert is. So Merriam-Webster says here, having and involving displaying a special skill, knowledge derived from training or expertise. The Oxford Dictionary says a person who has very knowledgeable about a skillful skillful in a particular area. That kind of sounds like her, right? 20 years. I give it to her. There's some of us that haven't been working in this field for 20 years and we're considered experts. All right. The history of an expert tells us that it's a Middle English from French and Latin expertise and a past principle of experiai or try. It's a noun that dates from the 19th century compared to with experience or experiment. All right. So, is Susy an expert? I would say yes. She's absolutely an expert in what she does. She knows how to regulate. She knows how to know when her medication is. She knows how much to draw up. And for 20 years, she's been doing it right. And then there was one morning. She works as the general manager of a restaurant. She puts in well over 60 hours a week. Our son was just born. He was, I think it was 3 months old. She went back to work. And she had worked extra hard that week. That morning, she actually went in early to open the restaurant, got off around 11 or 12, went home, took a nap for a little bit, then went back in and closed the restaurant and got home at 4 in the morning. She got tired. She got complacent. She was distracted, right? Fatigue, right? So she grabbed her insulin. And at 4:30 in the morning, when she hadn't slept, she got complacent, just grabbed one and drew it up and gave herself the insulin. I was in bed asleep, obviously, getting ready for work until he started to cry. And she's so quick. When he starts to cry, she's out of bed trying to figure out what's going on, and she's just there. And this morning, she wasn't there. I couldn't figure out why. And I looked over, and I heard him crying, so I grabbed him, and I went to shake her. And she was stiff, cold, and wet. And she was seizing in the bed next to me. And I was terrified. This is my love, my life, who's seizing in the bed. And I quickly grabbed my son, and I ran in, I called 911, and I got her glucometer. And I checked her blood sugar, and it was 20. And by the time the fire department got there, it was 12. I feared when they were there. You know, it's a completely different world when you're on the other side, to watch somebody do something. You know, I stood there and I was watching them do their IV. I was like, you better get that in the first try. Man, oh man, don't let me step in. And so I had to actually walk away for a minute and go talk to the fire captain and say, hey, do you need insurance? Do you need to know anything? Because I had to step out because it was too much. Too many factors were involved for me that I probably couldn't make a clear decision what was going on. So for her, we came up with, we saw this come up in one of our talks. We said, if you're hungry, angry, late, or tired, halt. Stop what you're doing. Check what's going on. If you guys are taking back-to-back flights, you're getting tired or you're getting hungry, stop for a second and get some food. That flight will either be there or someone else can help out. But it's bad news when you decide to forget all this. So what do we do to improve technology for her? We got her what's called a Dexcom. It attaches to her skin. It monitors her blood sugar. It sends her an alert when her blood sugar goes low. It sends me an alert on my watch. And so there have been times where I'm sitting in a meeting and my watch is going off and it's buzzing and it says urgent low blood sugar Susy. So I just send her a kind text. Hey babe, how you doing? And I check to see if she's responding with me or not. We also got that wonderful medication there, glucagon, in our house now, right? I taught her sister, and I taught our friends and family that come over how to use this in case of an emergency. So our checks and balances are now in place to prevent and also treat if something happens in the future. So we all know the checklist for our checklist for factors here. I'm safe. Can all these things hit us? I hit just about everything but the alcohol on that one and medication. I was sick to my stomach seeing what was happening. I was stressed out. I was fatigued. I had been up running around. She was fatigued, and emotion clearly took over. So let's tie that into our RSI checklist. So a checklist is not a recipe card for novices. It's a check to confirm that work has already been done by experts. A lot of arguments that I hear when we talk about RSI checklist was, well, geez, we're going to look stupid doing this. It's not that we look stupid. We're doing our checks and balances to make sure we're doing the best for our patients. And as my company says, giving more tomorrows. Right? We're doing that and we're making that happen. A little bit of evidence-based research. We see here that a development of standard operating procedure and a checklist for rapid sequence induction in the critically ill. In the bottom there, it says absolutely that this is an appropriate thing to do, to consider, and to gather further information on. Second paper here, a procedural checklist improves safety of emergency department intubation and trauma patients. So if the ER says we should be doing this, the operators are doing it, we even have on our critical care teams and our community paramedicine sepsis checklists. What makes us better? Are we that confident, slightly cocky, that we don't need to be using a checklist? I don't think so. So they did a big review and they looked at a lot of studies there and they tie it together, and basically in conclusion it says the current evidence base suggests that there may be potential reduction of adverse events. So we looked at adverse events in my company, and we built this thing called an out-of-operating room experience. So what we see here is adverse events and out-of-operating room experiences. In the ICU, we see one attempt, there was almost a 19% chance for an adverse event. That's damage to the airway, broken teeth, pneumothorax, main stem intubation, cardiac arrest, hypoxia, things that we look at like that. We looked within air methods, and we saw that we had a 7% in the first part there, first attempt. By a second to third attempt, it was almost 50%. Do I want to roll the dice? Do I want to make that decision and possibly have an adverse event? We tied it into the emergency department. There was a study done by Sackles and his team, same thing. And so we've all partnered as a team, a triad, and we're building an out-of-operating room experience. And we understand that a lot of things that we do are parallel to what an emergency department does, to even what an ICU does. And we're bringing that to fruition and showing everybody what's happening and how it's happening and bringing it together. So let's look at some current RSI checklists. So out of Greater Sydney here, we see their checklist. They read it back to each other. The person reads the first line, the partner says check. The person reads the second line, the partner says check. They go down their checklist. Okay. University of Utah, a little more dynamic. But they go into pre-oxygenation, their plan, their position the patient, prepare the equipment, and move forward from there. You can see as they build this together, they've built a dance, a song and dance with each other to make this happen. Okay, I have to also say that I'm a faculty member in the Difficult Airway Course EMS. So this is the Difficult Airway Course card. It gives us every bit of information that we need to have in terms of airway and RSI management, thinking about our algorithms, our plans, our preparation. What happens if we have a failed airway? What are our pearls? What should our time be for RSI? And they in turn also have built an airway checklist. A little more standard, a little more cut and dry, right? And the best part is oxygenate, resuscitate, anticipate. Okay. Air methods, we've built our checklist. And as you can see, it's very simple. It's not proprietary. We don't go over any drug dosages with it. We purposely don't do that so that what we do is we hand it to the lay provider. We hand it to the tow truck driver. So there's no selection bias. Because I know my partner always uses succinyltomidate and they always have their bougie out, so I don't have to go over those checkboxes. Well, what happens? They don't take out that one, or they use the wrong medication. And so we found that using this allows for that selection bias to not happen and allows for errors not to occur because someone else is there. There's always somebody going to be on scene wanting to help, right? And so this gives that person the opportunity, even if they're not a medical person, to feel like they're doing something, and it helps the flight crews out. And you bring everybody together, and you have a good cooperation with that. Side 2 is our heaven criteria. All right, this is what we're looking at challenging and looking at difficult airways and resuscitation. We're actually looking at this and have studied and shown great statistical significance that this mnemonic helps anticipate a difficult airway. When we look at the Lemons criteria, it's absolutely great criteria. It works really well in the operating room. We're looking at this at the emergent environment. And time again, we've seen that this has been successful in helping us determine and understand when should we use video, when should we use direct. It shouldn't just be an all or nothing. There should be clinical decision making by the crews. That's why we're paid the big bucks to do this, to go out there and do this and make those decisions. And at the end of the day, don't practice until you get it right. Practice till you can't get it wrong. So like that last airway they were talking about, that was a tough airway. What do you do? What options do you have? After you're done with that call, debrief it. Put it together for your teams and practice it with each other and see what you can do. All right? So let's put it all together. I'm going to show you guys a quick video here of our RSI checklist put into action.
Hey guys, we got a 30-year-old male was riding an ATV, not wearing a helmet. He was ejected, decreased responsiveness, having kind of a tough time getting a seal here. BP is 82/40, pulse is 145, sinus tach on the monitor, our stats are in the 80s.
Okay. He's diminished on the right side.
Okay, I'm going to go ahead and take over applying pressure.
I'm going to get ready to needle decompress.
Okay. Yeah, I'm having a hard time getting a seal with this C-collar. I'm going to go ahead and remove it. C-spine's still being taken with the head lock. For you to remove that, if you could go ahead and apply gentle but firm pressure to his crike for me.
I'm going to needle decompress the right side. Okay.
Take that sharp for you.
Thank you. I got a rush of air back.
Okay. Yeah, he's a little easier to bag.
Breath sounds are improved on the right side. His O2 stats are 96%.
Do you want to go ahead and opt to RSI him?
I think we should.
Okay. Do you want to use 100 of ketamine and 100 of rock?
That sounds good. I'll get that ready.
Sir, I'm going to have you go ahead and hold the face mask for me using a firm seal with 2 thumbs up, and I'm going to go ahead and prepare my equipment.
His heart rate is 100, blood pressure's 90/72, and his O2 stat is still 96%.
Okay, I'm going to go ahead and put him on capnography. Angie, I'm going to go ahead and hand this to you to hook up. Here's this.
We have a good waveform. His end tidal is 30.
Alright, here's my equipment. If you could hand this to me when I'm ready. Okay, I'm going to go ahead and take back over our holding seal. Here's our RSI checklist. If you could please read this to us to make sure we're not missing any steps and we're doing it as safely as possible.
AMC monitoring equipment in place.
Yes.
Consider fluid and blood resuscitation.
Yeah, we have fluids going wide open.
Okay. Non-rebreather and passive O2.
You know what? I forgot the nasal cannula. If you go ahead and turn that up to 15 liters per minute.
Head of bed elevated to 30 to 35 degrees.
Yeah, will you help me with that, please? Perfect.
SpO2s at 93% or greater.
Looks like he's at 96% right now.
Okay. BVM 2 thumbs up with PEEP and ETCO2.
Yes. It looks like we have an end tidal of about 30 with
Okay.
good waveform.
Open C-collar if present.
Yes.
Any heaven difficult intubation indicators.
Yeah, he's got a lot of vomit in his airway, so I'm going to go ahead and intubate him using the direct intubation and just followed by suction.
Okay. Your checklist now is the equipment, suction and on and accessible.
Yes.
Okay. CMAC on and warmed up.
Yes.
Induction agents and paralytics drawn up and doses confirmed.
I have 100 milligrams of ketamine and 100 milligrams of rocuronium.
Okay.
Okay. ET and alternative airways out and accessible.
Yes, I have a King airway out.
All right, we're on to induction intubation. Induction agents administered.
I have 100 of ketamine going in.
Okay.
It's in and flushing.
We'll give that just a few seconds.
Okay. Paralytics administered.
100 milligrams of rocuronium is in
Okay.
and flushed.
Okay, and we'll just wait for his jaw to relax. All right. I think we're ready.
Okay. Suction prior to intubation attempt.
Yes. So I'm going to go ahead and lighten it up. All right. Inserting suction. All right. Can I have the bougie, please?
Bougie.
All right. And a tube.
I have a 7.5 ET tube coming down.
All right. Seeing the tube pass through the core. This looks like I'm approximately 20 at the T.
The balloon is inflated.
Okay. Go ahead and pull the bougie.
Bougie is pulled.
ET placement confirmed direct visualization.
Yes.
Breath sounds, no epigastric.
No epigastric. Clear and equal breath sounds bilaterally.
Okay. And ETCO2.
Our in title is good waveform with 32.
Okay, if you want to go ahead and pull suction for me.
And tube secured and
Okay.
OG tube placed.
I'm going to grab the end title over here. I'm going to go ahead and drop in OG. Alright, OG is in place. I'm going to grab them both. Go ahead and remove the CMEC. There we go. I'm going to secure the tube. Looks like we're still 20 at the teeth. Okay, just secure it. Okay.
Post intubation sedation.
I have 50 milligrams of ketamine ready to give.
So all of our clinicians at Air Methods have seen that. All of our staff have gone through that training. They practice using the card, and we've seen some interesting things happen with it. We've also implemented the SALAD vomiting simulator, and that builds an extra level of confidence in how to deal with the vomiting airway when we're intubating. Dr. Ducanto is the designer of that, and you can see that it's pretty intense and effective. So this year, all of our clinicians have already had this video. They've had the hands-on training, and they've had our additional airway training. And we've seen a couple of things happen. Our first pass success went up 4% this quarter. So we're at 95%. That's pretty intense. It's pretty huge when we do 2,500 intubations a year. We collect the data on every single intubation. We have a data bank that has over 6,800 intubations. And we collect every single intubation. There's 259 data points, which is almost 3 million cells of data. So it's pretty cool and pretty evident that we see what we're doing is working. Our first pass success sans hypoxia has gone up to 96%. And our decrease in intubation time. So when we heard that, it takes too much time to happen, that video was 5 minutes and 25 seconds all the way through. Think about how long you spend on scene for an airway. Now, we don't want to stress the fact of getting off scene right away. We want to stress the fact that having extra hands there is more appropriate. We saw a 10% increase in desaturations when we intubated in flight versus on the ground. Our success was about the same, and I really believe it's because of the advent of videoscopic intubation. If we looked at that data 5 years ago, it'd be huge in difference. So do we want to have that 10% decrease in desaturation? I don't. There's not enough hands in the helicopter to help us if we have to. We can't properly pre-oxygenate those patients. We don't have as good suction as we do on the ambulances or in the hospitals. So why are we rushing off the scene just to make someone happy and not doing the best for our patients and giving them more tomorrows? Right? We had a decrease in adverse events and complications with this. So it brings back to human factors. Can we help mitigate those issues that we can potentially miss? You saw in the video, she forgot to put the nasal cannula on. The lay provider there said to them, hey, nasal cannula? Oh, you're right. Can we put that on? All right. So in summary, implementation of RSI Checklist can help streamline the process and shorten time. With practicing of this and working with your teams and working with your ground agencies, you can get to a flow with this, right? An RSI Checklist can help confirm the process and prevent those adverse events from occurring. If pilots, operating rooms, and community-based paramedics are using them, nuclear physicists are using them, why aren't we? Errors are inevitable, even for us flight crews. All right? There are situations that can increase the likelihood of this error. We need to recognize those for our patients' sake, and we need to make sure that we're looking at them and preventing them. Hence the RSI checklist and other things that we do, the sepsis checklist, those things. Human factors can cause adverse events under less than perfect situations. Right? So we have the complacency, the distraction, the fatigue, right? All those big things that we look at. How about pressure? Pressure to get off scene? Absolutely. Then our personal stresses. No one knows what's going on in your head about your personal life. So we got to think about that. So we don't kill our patients by being unable to intubate them. We kill them because we don't stop trying. We got to know when to stop and figure out what we're doing.
Folks, we really hope you enjoyed that lecture by one of the nation's best pre-hospital educators. Now, we have to remind you, this was just a little taste of everything that CCTMC offers. There's nothing like attending CCTMC in person So let's kick it to our IPP, our immediate past president of AMPA, Dr. Chris Fulligar, to give you all the details for CCTMC 2018.
This last CCTMC was, I think, the best one we've ever had, and I'm really excited about 2018. So mark your calendars now. It's going to be April 9th through the 11th, 2018, at the Wyndham San Antonio Riverwalk in San Antonio, Texas. We're also going to be having our pre-conferences the weekend before, so keep those dates open. Look out for the registration link, and I hope to see you there in 2018.
Chris, these pre-conferences are amazing too. So if folks have attended CCTMC but not come the weekend before, we definitely encourage you to check that out. This last go around with Dr. Jack Davidoff as a medical director, the surgical skills and cadaver lab were just incredible. I've never participated in an anatomy and procedural program like that anywhere in the country.
Yes, it is something that we continually get very positive feedback from, and something we continue to work on each year to make it better and better.
So lots to check out there, folks. Mark your calendars. You do not want to miss CCTMC 2018 San Antonio, Texas. And with that, this is Faizan Arshad and Chris Fulligar wishing everyone a safe tour and a happy EMS week.